without further delay, I'd like to introduce our first speaker this morning, and that would be Dr. Kristin Livingston. Dr. Livingston is one of our pediatric orthopedic surgeons here at UCSF Benioff Children's Hospital. She practices mainly at the Mission Bay campus. She went to UCSF for medical school, orthopedic surgery residency at Harvard, and then pediatric fellowship at Boston Children's Hospital. At UCSF, she serves as the Director of Education for our Division of Pediatric Orthopedics. She also serves as the Director of Physician Experience for our Department of Orthopedics. Her clinical interests include pediatric orthopedic trauma and limb deformity, and today she'll talk to us about torsional and angular development of the lower extremities in children. Thank you, Dr. Livingston.
Thank you so much, Selena. It's really great to be here talking with you all today. We're going to start the morning off with a bang, everybody's favorite topic of in-towing and other things as well. I have no disclosures. So our goal today is really to sort of understand what is normal developmental and what is pathologic in terms of torsional and angular development of children. So we're going to review the history and physical exam for rotational and torsional alignment and show some examples of what's normal and what is deformity. And then we'll also review the history and physical exam for angular and coronal plane alignment issues and also go through some examples of what's normal and what's not. So first to start out with torsion, right? So this refers to twisting, abnormality or twisting in the axial plane. So mostly this shows up as either in-towing or out-towing, and we get lots of consults for in-towing especially. So there's quite a journey of torsional development from a fetus in utero to a skeletally mature adolescent. In utero, the femur will be twisted anteriorly or internally. There is the hip joint sits externally rotated. The tibia is internally rotated, internally twisted, and then there's variable position of the foot. So over the first 10 years of life, a child is going to sort of untwist. This is this magical process of childhood skeletal development that happens on its own. So the tibia will externally rotate by about 15 degrees. The femur will untwist by about 25 degrees. So the first decade is really a moving target. But most of the time when there are concerns about this, it's a concern of in-towing. And while we see it as a foot issue, it can really come from any level in the lower extremities. So very commonly from the hip, from femoral antiversion, or from the tibia, from tibial torsion, or from the actual foot, which would be metatarsus adductus. So we'll go through all of those different problems. So first, when we're talking to the patient, we want to know, obviously, how old they are. That's the most important thing in pediatric orthopedics all the time, because the physiologic stage very much drives where they are in this untwisting process. And then how long the problem has been present. This is often something where parents will say it's been present forever since they started walking, so you want to get a sense of this is getting worse or getting better. And is it causing functional problems? So keep in mind, tripping is very common for a toddler. We get lots and lots of consults for in-towing causing tripping in a 2-year-old, and you're like, that's actually pretty normal. So tripping is normal when they're little, but it's not always normal for an 8-year-old, so those are ones you want to pay more attention to. And then symmetry, most of these issues are symmetric. Asymmetry raises a red flag. And birth history, is their normal growth curve, and family history, because obviously the apple doesn't fall far from the tree. So when we look at them, just getting a general sense of overall height and weight, are there any dysmorphisms? Is there possibly a skeletal dysplasia here or a syndrome? We want to look, examine their spine, look at their limb lengths, and that's usually an exam we do when they're standing. And then looking for neutral lower extremity alignment. When this is just an issue of torsion, their legs should be straight. So if you have them stand straight up, the knees and ankles should be touching. Torsion doesn't usually carry any coronal plane alignment issues. So we want to watch their gait. And please don't judge their gait before they start walking. Little kids who don't quite walk yet, it's hard to, a lot of people worry that, they put their feet outwards or inwards, and it doesn't really become relevant until they're actually walking. So the toddler gait is obviously very different, right? They have a very wide-based, externally rotated gait, but it becomes more of an established heel-toe gait by the time they're around 3, and then really doesn't fully mature until they're about 7. you want to pay attention to the inward or outward foot progression, right? So we look at the angle that the foot makes relative to the line of progression, and that's what sort of shows us the internal or external, or the in-toeing or out-toeing. And then also look at the position of their knee and gait. So sometimes the knee follows the foot, sometimes not. And then obviously looking at their overall coordination. But this sort of just demonstrates why you want to look at both the knee and the foot in gait. Sometimes you could have the feet pointing inwards, but the knees pointing straight ahead, or you could have the feet pointing straight ahead and the knees pointing outwards, or both the knees and the feet going in together. So just keep an eye on the foot progression, but also where that knee is landing in gait. So when we assess their rotational profile, this is really how we figure out where the in-toeing is coming from. You begin by assessing their gait, obviously, the overall attitude of the way that the limb is going. And then you want to assess their prone hip rotation to determine whether this is due to femoral torsion. You're going to assess their prone tibial torsion, looking at the thigh-foot angle, and then also looking at the foot to see whether or not the foot is curved. So the femoral torsion is assessed by putting a child prone on a table and then bringing the feet out like this, which is internal rotation of the hip, right? And bringing the feet together like this, which is external rotation of the hip. And in a child with a lot of internal femoral torsion, those feet are going to be able to come way apart. And you're really paying attention to see, is this very unbalanced? Do they have tons and tons of internal rotation and less external rotation, or vice versa? So this can show you if a child has more femoral antiversion or retroversion. And then these graphs sort of show you that this is a changing process over time. So the hips will have a lot more internal rotation early on in life and more external rotation later on in life. And then so this is just a nice picture of really what femoral antiversion is. It's the rotational angle at which the neck of the femur attaches to the shaft of the femur, right? So this is a normal femur on the left, which shows you that the femoral neck is just a little bit rotated forward, right? Normally about 15 degrees in an adult. But in a child, that antiversion can be huge, like even sometimes 50 degrees angled forward. And so that's what this twist of the femur looks like. And then this is why femoral antiversion causes in-toeing, right? Because if you have a normal hip, you see how the femoral head sits nicely in that socket with the knee and foot pointing straight ahead. But if you have a significantly antiverted femur, then that's not a comfortable position for walking, right? When they put their foot down and bear weight, they're going to want to rotate the whole limb internally to get that hip seated more squarely inside the hip socket. So it's really an issue of turning your leg like this when you put your foot down, because that brings the head of the femur more deeply inside the hip socket. And then this is just a graph that shows you how the femoral antiversion decreases over the first decade. So it's really this like long, slow process. And we often see these in-toers right around age 5, and we have to say, just be patient, it's going to get better. So femoral antiversion is usually the cause of in-toeing in school-age children. It should be symmetric. Children may trip and fall more than average because their feet are getting in the way of each other. And then everybody wonders, is W-sitting a problem? And it's really not. There's nothing that's been shown that W-sitting prolongs or perpetuates femoral antiversion. It's just the way that they're comfortable. And this may be in combination with other causes of in-toeing. It often can worsen for the first few years and then typically resolves around age 8 to 10. Again, it can be genetic. There's no role for bracing here. And really, there's almost never a role for surgery. Technically, you can do a femoral osteotomy to cut and rotate the femur if this is really a terrible functionally limiting problem, but that almost never happens. I think I've operated on 2 in-toers in 8 years. So it's not something we typically do when we say, well, we can cut your child's femur and rotate it. They're like, okay, bye-bye. So just important notes about the referral. We almost never operate on femoral antiversion. Physical therapy is not going to change the rotation. This is a structural issue. Bracing and shoe inserts are also not going to change their in-toeing. And then in terms of like when to address this, you will never miss the boat. This is not amenable to guided growth techniques. And this is something that we would never operate on until at least age 10. So that's femoral antiversion. Right now, just a quick word on tibial torsion. So this, on exam, you're going to examine by the thigh-foot angle. So again, you place a child prone, you bend up their knee, and you look at the angle that the foot makes relative to the thigh. And that's going to show you that the tibia is either twisted internally or externally. And then again, it's a changing process through growth, it starts out relatively internally rotated, and the tibia will untwist over time and end up relatively externally rotated. And internal tibial torsion is typically the cause of in-toeing in toddlers. It's mostly symmetric. It's thought to be due to intrauterine positioning. Tripping and falling is very common, right? You got your toes tripping over each other. But again, no amount of tripping as a toddler is abnormal, right? Toddlers fall all the time. That's what they do. They're very good at it. And so again, this can be in combination with femoral antiversion, for example, but typically the tibial torsion will improve slowly by around age 3 to 4. And then notes about referral. So we almost never operate on tibial torsion in healthy kids. Spina bifida, et cetera, different story, but in healthy kids, we almost never have to manage this. Physical therapy is not going to change their rotation. It said sometimes it can help with clumsiness, but it's not going to change their alignment. Bracing and shoe inserts are also not going to change the rotation. And again, you'll never miss the boat on addressing this. This is not amenable to guided growth. We can fix it anytime, but we almost never do. And families are extremely unlikely to want osteotomies, even in severe cases. So then the other thing that can cause in-toeing, of course, is metatarsus adductus. So this is the curved foot where you have a curved lateral border. You also look at your heel bisector line here. So the heel bisector line normally goes through between the second and third toes, but it's more lateral than that in a metatarsus adductus. And you have to differentiate this, obviously, from a club foot, right? But a club foot has all the other deformities as well, the hindfoot varus, the equinus. And so in metatarsus adductus, the rest of the foot is normal. It's just curved when you look at it from the top down. And the etiology is probably intrauterine molding, and then it often has this trapezoidal shape of the medial cuneiform. It's pretty common, happens about 1 in 1,000 births, but more common if a sibling is affected. There's a higher rate in males or twin births or preterm neonates, and there is a possible correlation with DDH. So we do recommend screening kids with metatarsus adductus with a hip ultrasound just to make sure they don't have hip dysplasia. And this is the usual cause of in-toeing in the early days. And this can also be caused by a hyperactivity of the abductor hallucis muscle, which just makes that big toe sort of really reach over and curve inwards. So in terms of how we treat this, it's really based on the flexibility. So in a flexible foot, which corrects beyond neutral, we're just going to observe that. Usually it gets better. If there's a partially flexible foot, meaning that it only corrects just to neutral but not beyond, we usually do some stretching and maybe some casting. And then if it's rigid, then that's something we're going to treat earlier with casting or some spring-loaded orthotics. But just sort of busy slide, but the main point of this slide is to say that all the causes of in-toeing typically end up okay. So it's really rare that we need to treat in-toers. And then I always like to remind parents that, these are a few in-toers being awesome, right? So Andre Agassi and Michael Jordan and John Elway are some examples of some high-level in-toers, and some people even think that in-toeing makes you run a little bit faster. External rotation and out-toeing is really less common, but this can come either from the hip external rotation contracture of birth, from external femoral torsion, external tibial torsion, or pes plana valgus, right? We don't see it as much. When they're a baby, they always have their legs are externally rotated, right? The kids put their feet down widely and externally rotated, and that's because in utero, they develop this soft tissue contracture. So their hips, even though they have femoral antiversion, the hips are externally rotated when they're little. It's a common finding during infancy. So this external rotation contracture hides the normal increased femoral antiversion, if that makes sense. But then it goes away. And then you can have external femoral torsion. So this is more common in older children. Okay, so this is when they walk out-toed because their hip is externally rotated in gait. This is often hereditary, but keep in mind if this is acute, if this is a new problem or unilateral, we consider things like leg Calvi-Perthes disease or especially a skiffy in an adolescent. So pay attention to new out-toeing. You can also have out-toeing from external tibial torsion, where you have external rotation of the feet relative to the thighs. In severe cases, this can cause issues with gait inefficiency and difficulty running. And then sometimes you'll see out-toeing due to flat feet. So this is normal in young children. Most toddlers do not have an arch. We don't expect them to. They develop it over the first 6, 7, 8 years of life. And then flexible, painless flat feet are normal and do not need treatment. So that's a whole other topic. And then you can have these weird combination deformities of different axial alignments, right? So this is, in this person, you can see that the femurs are rotated inwards and the feet are rotated outwards, right? So when the feet are together, the knees are pointing in. When the knees are straight out, the feet are facing outwards. This combination deformity of femoral antiversion and external tibial torsion is called miserable malalignment syndrome, which is kind of a shocking name, but it often does cause some significant knee pain and difficulties in gait. And so every once in a while, this will need to be treated. This is how we assess the different rotational alignments on axial imaging. And then this is one that we actually may treat because it does cause so many problems. So we would treat this with acute rotation of the femur and a gradual rotation of the tibia, but that's obviously a big thing for a kid to go through. Oh yeah. What would be the clinical presentation? Knee pain. And to be honest, when miserable malalignment comes in, the main thing, parents are like, they just walk differently. They just look weird, right? And because people can't quite get a handle on what's going on, it's an awkward gait. Their knees are in, their feet are straight ahead. And so it's often like we can't quite put a finger on it, but they just look like they walk differently. And then they also have knee pain because that's something that stresses the patella. Okay, so that's torsion, and then we'll go quickly through some coronal plane alignment, right? So I want to make sure everybody's clear that we think about axial issues differently than coronal plane issues, right? So this is when you're looking at somebody in the frontal plane and the way that their legs look to you in that plane, as opposed to torsion, which is an axial plane twisting issue, right? So this presents as Bowlegs and knock knees. And again, when we're talking to the patient, age is extremely important because we'll talk about the moving goalpost of coronal plane alignment in childhood. And we want to know if there's progression, if there's change. Is this getting better? Is this getting worse? Is it causing functional problems? This is one that might actually cause pain. And is it symmetric? Or most of the time we think of these as symmetric issues. Certainly we want to think about metabolic and dietary issues because this is something where rickets could come into play or other metabolic bone diseases. And then we want to look at their growth curve because skeletal dysplasia is often also something that can cause a coronal plane abnormality and family history. So looking at their physical exam, so most importantly, we look at their limb alignment, right? And that can be standing or supine, usually both, with their knees extended, the kneecaps pointing straight up. A neutral alignment would be when the knees and ankles both touch. Genu varum would be, or Bowlegs, is when there's when your ankles are touching, but there's space between your knees. And then genu valgum, or knock knees, is when your knees are touching and there's space between your ankles. So my sort of rule of thumb with what's an important amount of varus or valgus, when you can put your hand straight between their knees or your hand straight between their ankles, that's a clinically important amount. And then angular development, just like torsion, and we talked about that, changes a lot over the first decade. Angular development also changes a lot as well. So little babies, they're quite bow-legged, right? Little 18-month-olds especially. They're varus when they're born, okay? And then they sort of cross around age 2, they neutralize, and then go to valgus, which peaks around age 4 to 5. And then they hit their normal mature alignment by around age 6 or 7. So you can see this sort of curve. Again, it's very much a changing picture throughout growth. And this is, again, just the picture of the little 12 to 18-month-old baby with little toddler with bow legs. And then usually the 2-year-old is going to have pretty neutral alignment. The 4-year-old is going to look very knock-kneed. And then the 6 or 7-year-old should really look nice and straight. So this is we watch this happen. We expect resolution in most healthy kids. And we wouldn't intervene very early for this because, again, we expect it to resolve on its own. This is how we assess it radiographically. So we look at the mechanical axis, and the mechanical axis is, so first of all, we take an x-ray from hips to ankles with a child standing with their knees straight and the kneecaps pointed straight ahead. And then we look at the line that we draw between the center of the femoral head, which is the center of the hip joint, and the center of the ankle. And that line is called the mechanical axis, and it should go straight through the center of the knees. So this is how we assess this radiographically. If it misses the middle of the knee, that's what we call mechanical axis deviation, and we would, actually give like a, 2 centimeter mechanical axis deviation. It's often, sometimes kids can look a little knock-kneed or a little bow-legged, but, their soft tissues can play tricks with us every once in a while. So this is sort of the real objective data about what their skeletal alignment is. Obviously, those knees are designed to take the force right through the center. And so if you've got your mechanical axis, the line of force, very laterally or medially deviated, that's not necessarily going to be healthy for your knees in the long term. So those are the things that can drive like knee arthritis later in life, which is why we care. This is another just very busy slide of how we assess these things, but these are all the angles that we draw to really determine exactly where the deformity is coming from in the lower extremity. So most of the time, this is physiologic, and especially in little toddlers. So physiologic genu varum is the most common cause of Bowlegs in toddlers. We see it more in early walkers. It's very commonly paired with internal tibial torsion as well, so you get these little Bowlegs with the twist. And this tends to resolve by about 2 years. But varus over age 2 is abnormal. But I will say we always get the consults at about 18 months old, and just wait a little bit longer because that's going to be when things resolve on their own. And so this varus, again, should resolve by age 2. It's abnormal after a child is 2. And then this is just called the cover-up test. This is sort of how legs can play tricks on you, especially when there's a little bit of internal tibial torsion. If you cover the bottom of the leg with your hand, you can see that knee is actually in neutral alignment, even if it looks bowed. So then, but pathologic genu varum it shows up, and it can occur from a variety of problems. So we see Blount's disease, right, which is a very common issue, and that's something we want to pick up early. We can see genu varum in rickets and things like renal osteodystrophy, but loads of things, skeletal dysplasias like achondroplasia and osteogenesis imperfecta. And then certainly other less common issues like osteomyelitis can lead to physeal damage, or trauma can do the same thing and lead to growth alignment issues, or even things like radiation. So, but just a word on Blount's disease. So this is a disease of the medial proximal tibia physis. It can happen either as early onset or late onset. More common in African American population, obese patients, and early walkers. Tends to be bilateral in the infantile cases. They may look normal at birth, but sort of develop these Bowlegs over the first couple years. And it's we mostly see those Bowlegs, but it's a combination deformity of varus, procurvatum, and internal rotation. And then the late onset cases are just, they tend to present more in adolescence, and it's more commonly unilateral. We assess this on radiographs again by drawing some angles. This one is the metaphyseal diaphyseal angle, and we look at the alignment of the growth plate relative to the shaft of the tibia. And in this case, we can take this x-ray around age 2 or 3 and have a decent sense of whether this is going to be something that resolves on its own or something that progresses to Blount's disease. So an MDA of over 16 degrees has a very high rate of progression to Blount's disease. But this is what it looks like around age 3 to 4 in a case that really, really desperately needs to be treated. And in severe cases, we classically have done osteotomies around age 3 to change this alignment and sort of save this physis. Though now more and more we're trying to do these with guided growth and avoid the big osteotomies. But these kids can end up having a lot of surgery over their lives to manage a very complex multiplanar deformity. And this is just another example of Blount's disease. We classically correct these with gradual correction with a frame, okay? But in the cases where kids are still growing and we have an open physis, we have the opportunity to do a guided growth technique. And then in terms of the referrals, so we recommend referring Bowlegs when they are over 2, because if it really is a Blount's disease or something like that, we want to know about this early before that physis really becomes irreversibly damaged. And so oftentimes, around age 2, if there's a significantly impacted kid, we're going to maybe even do bracing for them and possibly surgery as early as 3 to 4 to avoid a really diseased physis. And then Genu valgum, so that's the opposite way, the knock knees. And this is pretty common and usually normal. This is normal in a child of less than 7. There's no role for bracing here. It's ineffective and unnecessary. We just expect this to get better on its own. And even, again, being able to put your hand through the ankles of a 5-year-old, that's totally normal. But we monitor that distance over time. So we'll actually measure, the number of fingers that you can stick between their ankles and see that that's getting smaller and smaller as they grow. But then certainly there are lots of examples of pathologic Genu valgum. So this, even just in idiopathic cases, they may not resolve by age 7. This was more common in obese kids or kids with ligamentous laxity. Some kids will have hypoplasia of the lateral femoral condyle. And it can happen in post-traumatic cases as well, where you have an injury to the physis. So this again is just normal, idiopathic, healthy kid that didn't resolve. But then this would be an example of traumatic here. This is called a Cosen's fracture. And while it's typically non-displaced early on, we do have to watch this one because it can lead to a growth abnormality where the leg grows into valgus. Usually gets better, but still something that bears monitoring. And then, but also a growth arrest from a physeal fracture can lead, or from infection as well, can lead to problems with growth and malalignment. And then, of course, metabolic bone disease classically can cause severe Genu valgum. And so these would be things like either rickets or renal osteodystrophy. And this is an example of an X-ray with findings of rickets, right? Those growth plates are widened, abnormal, frayed. There's physeal fraying and cupping. This is what we see in cases of rickets. And then other causes would be things like, neuromuscular disease or dysplasias, right? This is a case of multiple epiphyseal dysplasia, and these are tough ones to manage. But all kinds of things can cause Genu valgum. The important thing is that we do, address and treat this. This is not the very benign situation of in-towing. This actually can lead to problems later on, right? We worry about that imbalance of the forces going through the knee, and we don't want that to lead to problems later in life. Treating the metabolic and reversible causes can actually lead to spontaneous improvement. So when we have kids who show up with rickets and severe malalignment, once they start getting on medical management, they can actually straighten out on their own with surgery as a backup option. But orthotics and shoe modifications are not going to be helpful here. And once they do hit that age of around 10 and they're still knock-kneed, then we would recommend doing guided growth for a lot of those kids if it's a significant amount. Guided growth patients are extremely satisfied. This is like one of the smallest and easiest surgeries that we do, and just the most satisfied patients. They love their straight legs at the end. And but we just put these little plates and screws across the growth plate, let them sort of cook and grow for a little while, and then all of a sudden they have straight legs and we take them out. So that's a satisfying correction to give them a neutral mechanical axis so that those knees are healthy for the rest of their lives. But when they're done growing, we don't have that option of guided growth anymore. And so in that case, we might turn to a femoral osteotomy to acutely realign the bone. And that's easy enough to do. It just is a bit harder on the patient because of the non-weight bearing and everything afterwards. So in terms of referrals for knock knees, healthy kids with mild knock knees should be referred around age 8 to 10 for discussion of surgical options, because if you're still knock-kneed around age 10, it may not go away. But then certainly with the kids that are severely affected, or where it looks like a pathologic case, then we would want to see those kids early to address any treatable causes. And that is all I have. So I'm happy to take questions if there are any. Oh, questions at the end. Never mind. Okay. Bye, everybody.